Good afternoon, everyone, and thank you for joining the Idaho Falls Rotary Club for today's Idaho Falls Online Lunch-In. We apologize for being a few minutes behind this morning, but we're happy that you're here with us for today's program. Before we get started, I do have a couple of announcements. The first is some recognition for some of our club members. Since 1957, Rotary International has awarded the Paul Harris Fellows recognition to acknowledge individuals who contribute or have contributions made in their name of $1,000 to the Rotary Foundation. Today, I'm happy to recognize 3 Paul Harris Fellows from our club. Mary Lynn Hartwell has received her Paul Harris Fellow plus 8. Lindsay Romancu has also received her Fellow plus 8. And Gina Stevenson has received her Paul Harris Fellow plus 7. Each will be receiving a pin to commemorate this achievement. Thank you, Mary Lynn, Lindsay, and Gina for your generous support of the Rotary Foundation. On another note, I'm sad to recognize the passing of one of our club members, John Lobuono. John joined the Idaho Falls Rotary Club in 1988 and has been an active member of our community since that time, having served as a board member for many community organizations, including the Idaho Falls Rotary Club, the University of Idaho National Alumni Foundation, the Idaho Falls Symphony, Idaho Falls Parks and Recreation Commission, and the Idaho Falls Auditorium District. John was a principal owner in Lobuono and Associates and Eagle Rock Productions and was a licensed realtor with Century 21 Greater Land Co. Realty. John will be greatly missed. At this time, I'd like to turn our program over to this month's programs chairs, Carrie and Jerry Scheid, to introduce today's program.
Thank you, Michelle. Happy New Year, everybody. So I have the pleasure of introducing Dr. Ken Krell, who grew up in Port Huron, Michigan, and attended Michigan State, where he graduated magna cum laude with degrees in journalism and history. He completed his residency in internal medicine at the University of Washington. After that, he came to Idaho Falls, where he practiced internal medicine with an interest in critical care. After retiring from 30 years as IRMAC's ICU co-director and quality improvement director, he now continues to practice medicine and teaches medical students and residents. He has a clinical faculty appointment at the University of Washington and is currently on the State Medical Advisory Committee for COVID and is chair of IRMAC's COVID Crisis Management Committee. So who is more qualified to talk to us about COVID and vaccines and such as Dr. Ken Krell? Please welcome him.
Thank you. You hear me okay? I'm grateful to be able to speak to you today, especially to such an organization as the Rotary Club, who has such a remarkable track record in global health. So it's a real pleasure to be here. I got my second vaccine on Monday, and I'm grateful for that. And I'm thankful that the greater community has seen fit to get healthcare workers vaccinated. It's been a huge load off us, and I'm grateful for that. And we're going to spend some time talking about vaccines. But I'd like to discuss 5 topics today, kind of rapid fire. We'll move through them quickly. The first is where we're at with case numbers in the state. The second is where we're at with vaccines, realizing that I am no expert on vaccines, but I've listened to things and particularly with the changes that have occurred this week. The other is to talk to you about some new treatments and testing. And then I want to discuss post-COVID syndrome, the long haulers, and the implications that's going to have for us. And then I have to make a brief political statement about the threat to our public health structure by the legislature. So if I can have my first slide, I want to look at case numbers, and it's interesting where we stand in the state compared to elsewhere. Is the slide up? Okay, I don't see it. It's not on my screen. It's not on my screen. That's fine. Okay. So at any rate, I think any case numbers we get reported are suspect, since we still have over a 16% positivity rate. And so we know we're grossly under testing. But what is reliable are the hospitalizations and the case numbers. Right now we have a case fatality rate of about 1.03%. That's kind of typical from around the country. On the 12th, Department of Health and Welfare reported 709 confirmed and 303 probable deaths. And at ERMAC, yesterday we had 200 inpatients. 21 of those were COVID, 9 ICU COVID patients. And we had 20 total ICU patients. The day before we had 27. So our COVID numbers have been remarkably decreasing. And we are still having staffing issues. We still have our surge capacity beds open. But I think we have to be pleased that as a state, we have not seen the increase in case numbers that many of us, including me, anticipated we would see after the holidays. Yesterday, there were over 4,000 deaths reported in the country, and yet Idaho has stayed really quite remarkable on our case load. And I think that says something about what we're doing right. That we have to continue to maintain our vigilance, but certainly at this point, we ought to be grateful to the population that what we are seeing is in real contradistinction to what the rest of the country is seeing, and that we're doing something right here. If I could have slide 3, I'll look on my notes here. I want you to look at the age group for COVID-related deaths. And that has a lot to do with where we're going in terms of vaccination. As you can see, above age 60, the incidence of death increases greatly. And so that's got to be reflected in how we're looking at vaccine rollout. Next slide, please. I also wanted to show you that what is reliable are patients currently hospitalized in inpatient beds and hospitalized in the ICU. Those numbers don't lie, and so I think there is a reality to the downward trend in cases that we're seeing here. The other, if I can have the next slide, to look at patients hospitalized by age group. As you can see, it increases greatly starting at about 60 years. We certainly are seeing a fair number of younger cases, but the bulk of disease that we're seeing is still in older individuals, and that's going to be reflected in our getting long-term care patients vaccinated, as well as those patients over age 65. I want to talk about vaccines for just a minute. Things changed radically yesterday, as some of you may know, with an announcement by the federal government that, in fact, they are going to release all of the doses that they have available. They'd been holding doses back for the second vaccine, but it's been a difficult distribution system. We've never done this before as a country, and so the feds are releasing all of the doses as they become available without holding them back. The second thing that's occurred both at the state and at the federal level is the recommendation that the next phase of vaccination should include all individuals over age 65 rather than age 75. So we've increased the pool of the next phase of the public who are going to be eligible. The third is that vaccines sitting on a shelf and not in people's arms are not helping us. And I think we're learning that rigid categories that we complete, for instance, healthcare workers, then we move to long-term care, then we move to EMS, that system isn't working. that we have, for instance, at ERMAC, spent the last month getting all of our healthcare workers vaccinated. So we're going to see now some real overlapping in the categories, which makes sense because you ought to be able to start a second category before you're done with the previous, or we're going to have a lot of vaccine sitting around. It's interesting that though we've had 155,000 doses distributed to the state as of this week, including 71,000 Pfizer and 84,000 Moderna, we've so far only used 33,000 of those. So only about a fifth of vaccines that have been distributed to the state have been, in fact, put into the arms of the public. So we're going to see some changes. Yesterday, Governor Little announced those changes, and then there was a press briefing by Director Jepson of the Department of Health and Welfare. If I can have the next slide on the prioritization, what you're seeing now is that we are currently vaccinating long-term care facility residents and finishing up healthcare workers. But that we're now going to move to EMS personnel, police, and educational workers, teachers and employees of schools. That priority is so that we can keep students in school. Then it's anticipated that about February 1st, we'll start vaccinating all individuals over age 65. That may be an overly ambitious timetable. Time will tell. There are about 500,000 Idaho residents over the age of 65. And then about mid-February, start vaccinating agricultural workers, public transit workers, essential workers such as grocery workers, and those below age 65 who have comorbidities that make them more susceptible to COVID and for more complications. We're anticipating then that somewhere between April and May, the vaccine will be available to the general public. If you can quickly flash up slides 7, 8, and 9. 7 starts to show how these groups are made in terms of who's 1.1, and then we go on to 2, and then we go on to the third group. Those slides are available on IdahoCoronavirus.gov if you're not sure of where you're going to be listed in that prioritization. The other thing is that as of next Monday, that website from Department of Health and Welfare will also have a link that you can go into, find out where you're at, and make a reservation with a healthcare provider. Right now, there are 247 providers. I think those are mostly clinics and hospitals rather than individual physicians. And they supposedly will have financial assistance by next week. And given that, then, the plan is that by next week, you can essentially make a reservation and find out the time frame and get matched up with a provider. So that's going to be important for people to do starting next week. I want to talk a little bit about side effects of the vaccine because there's been much said about this. I got a sore arm with my first vaccine and minimally with my second. It's a very common occurrence. About 83% of recipients will get a sore arm. It's interesting that as we get older and our immune system is not so vigorous, that side effects are less in older individuals, such as me. Fever that occurs in maybe half of people. It's generally mild. It's only severe in about 1 to 2%. there's fatigue and some headache and chills and muscle aches and joint pain. Those things may last for a period of hours to a day, seldom beyond that, and are certainly not a reason to avoid the vaccine, and ought to give you some assurance if you get those that your immune system is reacting appropriately. Anaphylaxis has been a rare occurrence with the vaccine, and certainly people with a history of anaphylaxis or IgE-mediated disease do need to be watched for a longer period of time after getting the vaccine. But because their active immune system may make them more susceptible, it's very important for them to get vaccinated. And it may be worthwhile, if you carry an EpiPen with you for anaphylactic reactions, that you take one with you to your vaccine site. But those complications have been exceedingly rare. The other thing that I would suggest is that if you get fever or achy, use acetaminophen, use some Tylenol. Don't use nonsteroidals, and certainly don't take steroids. You don't want to blunt your immune response, and those symptoms are an indication that you're getting a good response. The other thing that is important in both maintaining our vigilance at this point in terms of distancing and not getting together in large gatherings and in masking are the new mutations, which we've all heard about. Fortunately, those mutations appear to be just as susceptible to the vaccine as the older mutations. That those mutations have not affected where the mRNA antibody attaches to the spike protein. So while those mutations are going to increase our risk over the next several months of a number of cases, they appear at this point not to have affected the efficacy of the vaccine. And I believe there are even more reason for us to get vaccinated. You've heard some debate about whether, given the slow rollout, we ought to be concentrating on just getting everybody one vaccine as opposed to two. As you know, in the trials, they were done, the Moderna and the Pfizer were done with two vaccines. And we know that, for instance, for the Pfizer, the efficacy is 95% effective 7 days after the second dose. And that includes high-risk groups. That was pretty much the same across the board. So the efficacy is very high. It occurs very quickly after that second dose, which for Pfizer is at 3 weeks, for Moderna is at 4 weeks. And in addition, it protects from severity of disease. Of 10 patients with severe disease in the phase 3 trial with Pfizer, 9 cases occurred in patients in the placebo group, only 1 in the severe group. So you have 95% efficacy plus protection against severe disease. Efficacy begins, the lines of separation in number of cases begin very early as 12 days after the first dose. But however, the efficacy of one dose is only 52% overall, as compared to 95% after a second dose. So I think most epidemiologists, and I'm not one, and it's not an area I have any expertise in, but I think most epidemiologists would trade the number of people who could be vaccinated once versus 2 doses for the increased efficacy of 2 doses. So at this point, we're all staying with a 2-dose vaccine. The other issue that comes up is, what if you've had previous COVID? There's a study from Nashville in healthcare workers that showed 58% of healthcare workers who had COVID were seronegative after 60 days. That is, you could not identify antibodies in those patients. And thus, we believe that will correspond to risk of reinfectivity. So it is important for individuals who've had COVID to get to get vaccinated. And the incidence of second infections, the risk is higher in patients who've had mild disease, who will not get as vigorous a natural immune response. So it is very important for people who have had COVID to get vaccinated. The antibody levels in those patients who remain seropositive drop by about half at 60 days. So certainly natural infection does not induce long-term resistance to the coronavirus. What we don't know is how long immunity lasts after the vaccine. It appears at this point that it's about good up through several months, but we just don't have data out longer than about 6 months from some of the earliest patients enrolled in the earlier trials to know. So we're uncertain at this point whether in fact we're going to require, for instance, a yearly vaccine. I'd like now to talk about new treatments and testing. We've all relied on PCR testing throughout this epidemic to identify active cases. The problem is PCR tests have to amplify parts of the virus, and they're unwieldy. They take a long time to do. They're expensive, and it has been a bust. If you get a test back in 3 to 5 days on whether you're COVID positive, it's of little use to anyone, either for you in isolating or in terms of case control. The antigen tests that are now available, we all had some reservation early about them having decreased sensitivity. But what we've learned is what that means is that the antigen and the other is called a molecular test, but they're both easy to run. They can be run in about 30 minutes. They cost about $5 to produce. And what they tell us is who's infected, because if the test is positive, you're infected. And so late in the course of disease, the test may be negative, but it doesn't matter. You're not infective at that point. Early in the disease, before development of symptoms, shortly after exposure, the viral reproduction may be low enough that the test is negative. If that's the case, the test is cheap to run and can be run in 24 to 48 hours if there's a question. Those tests have now become readily available. All institutions are doing them now on symptomatic outpatients, including us. For a while, there was a real shortage of tests, and we could only run those on patients who were going to be hospitalized. That's no longer the case for most all institutions. One of the things then that's led to is that there is an emergency use authorization for a monoclonal antibody, and I can never pronounce this, called bamlanivimab. Just remember it as the monoclonal antibody. You can kind of think of it as a super convalescent plasma. The data for convalescent plasma really hasn't panned out very well. But bamlanivimab in the BLAZE trial, in patients with mild disease who are still likely in the viral replication phase, had a significant decrease in overall hospitalizations. In the placebo group, 6.3% of early disease patients required hospitalization, as opposed to 1.6% of patients in the overall group with the monoclonal antibody. Importantly, however, in high-risk individuals, that is patients with BMIs above 35, chronic kidney disease, diabetes, immunosuppression, patients over age 65 or greater than 55 with coronary disease or hypertension, and in some high-risk children, the decrease in hospitalization was much more dramatic. In the control group, 15% of patients required hospitalization at a later date, as opposed to only 4% in the patients who were high risk, seen as outpatients, didn't have severe disease, could be discharged. Only 4% of them, as opposed to 16%, required hospitalization. What that means is that this is an important treatment for patients at high risk early in the course of the disease. And the earlier you get the monoclonal antibodies, so you stop the viral replication, the better. So it's important, if you get COVID symptoms or you've been exposed and get symptomatic, that this treatment is available. It's available at a number of places and certainly at all ERs. And it does significantly decrease your risk of hospitalization. If we have a treatment that can decrease the number of people that I have to see almost fourfold who are at high risk of disease, this can make a tremendous difference on hospitalization and death. So I would encourage people who are high risk, who are over 65 or have those other risk factors, to strongly consider seeing your healthcare provider early in disease, because this antiviral, if you will, by binding the virus, is only effective if given early. It's expensive, but it is incidentally covered by Medicare. I'd next like to turn to talking about what have been called long haulers. I think the importance of this is, as we get control of this pandemic, patients with, I think long haulers is a terrible term, patients with post-COVID syndrome or chronic COVID are going to be a huge burden on our healthcare system. We define it as patients who have symptoms for longer than 3 weeks as post-COVID. Chronic COVID is longer than 12 weeks. We know that in critically ill patients before COVID, many suffer chronic disability after hospitalization in an ICU. Up to 84% of patients that I've been able to discharge in years from the ICU continue to have symptoms, be they cognitive symptoms, thinking systems, mental health issues, physical functioning symptoms, and those tend to persist for up to 6 to 12 months after discontinuation of care from the ICU. So it's not surprising that we're seeing symptoms in COVID patients after they leave the ICU. However, one of the things that's been interesting is those cases in post-COVID patients are occurring disproportionately in patients with mild disease, particularly in young people. A study from Italy showed that 125 of 143 patients still had symptoms 2 months after their initial onset of symptoms. A study in the UK estimates that 10% of patients are going to have prolonged symptoms. And a study from the CDC showed that 35% of patients are not back to their usual health by 2 weeks. That includes 26% of patients in the ages 18 to 34. So we're seeing long-term disability from COVID that's been unusual, that we've not seen in other viruses. Up to 47% of patients age 50 and older have had prolonged symptoms. So it occurs in older individuals, but it's been surprising that it's occurred in a number of young patients who've had relatively minor disease. Those symptoms tend to be shortness of breath, fatigue, chest pain, heart and lung and brain dysfunction. Of concern is that we've got a couple of MRI studies of patients that show that after 7 days after diagnosis, 78% of patients with COVID requiring hospitalization have identifiable abnormalities on an MRI of the heart. That is, they have what we would refer to as myocarditis. It's not quite clear whether this is direct invasion of the heart or related to the vascular complications that occur. A study that's disturbing in 26 athletes looking at MRIs of the heart showed that 46% of them had identifiable myocarditis after infection, and these were elite athletes. So the post-COVID complications are certainly going to be significant. For instance, in patients hospitalized with pulmonary symptoms, with COVID, pneumonia, 64% at 3 months still have pulmonary symptoms. 71% have radiographic abnormalities. So we're going to be grappling with this. One of the commonest symptoms to occur is what's in the popular press been called brain fog. Difficulties with short-term memory, trouble with concentration, along with the other neurologic symptoms such as loss of taste and smell that can persist for months. I had a patient tell me everything just tastes like cardboard months after illness. So those are going to be issues that we're going to grapple with. It is one of the reasons that young people need to be cautious that getting disease for them is not simply, I'm going to be sick for a day or two. We've certainly known it wasn't the case in older individuals, but also for young people, the morbidity following disease is really quite significant. The last thing I want to address, and then I'd like to take some questions, isn't an area I have any expertise in. But having dealt with the Eastern Idaho Public Health Department over this past year, and having sat on the State Medical Advisory Committee and as a member of the Crisis Standards of Care Activation Committee, I believe it's a grave mistake for the legislature to threaten to upset our public health structure, which is what I believe they're looking to do. I've had disagreements with the aggressiveness both at the state level and at the local public health level. But I think we have to recognize that for the most part, the system has worked. And that for us to upset that system, I think is a real mistake. I think, for instance, Chairman Reed and our director at the Eastern Idaho Public Health, Jerry Rakow, have and the commissioners have all been thoughtful and deliberative, and that there is a real advantage in keeping the system intact that we've got. As you know, that the legislature is looking at a constitutional amendment to require a special legislative session within 30 days of a declaration of emergency by the governor. And they're looking at limiting the authority of district health boards and cities to implement emergency mandates. I would ask us to consider whether that's a body, the legislature, that we really want to turn control over. Having watched what's occurred over the summer and fall in terms of a legislature that is not diligent about masking or social distancing, that they're in court now for endangering legislators by their laxity and their cavalier attitude toward masking, and that we have a system that works, and it would be a mistake to upset it. Over 70% of Idahoans support masking and other measures, and just gutting that system would seem to me to be a mistake. I think there are 5 real quick reasons to do that, to leave our system intact. Currently, we now have a reasonable separation of power between the governor and local government and health boards that would be destroyed if the legislature had the entire power. Number 2, that the legislature is too slow to respond to disasters and epidemics. Number three, that there's an advantage of local control by elected officials who know their population, know their local circumstances. And I think we've seen that in Eastern Idaho public health at our local level. That has not been the case across the board in all of the districts, but I do think that we've seen that locally, that it's an advantage to have local authority involved in that decision making, and it's the conservative thing to do, to leave government at the local level with the authority. The other thing that's been said is that these are not elected officials. I think you have to remember that the public health boards are made up of a commissioner from each county who has been elected, along with physician expertise appointed to the health boards. These are elected officials. And lastly, perhaps most importantly, I think we ought to keep in mind that for some damn reason, things are working in the state of Idaho. And to upset that balance, I think, is not in our best interest. That's my political statement. I'll leave it alone at the moment. But those are my remarks. I know we ran through that quickly. I'd be glad to take any questions we might have.
Well, thank you, Dr. Krell, for a very informative update on the COVID situation and vaccines. I do have a few questions. One is, how do you think our healthcare workers locally are holding up, and what can we as citizens do to help them?
I had two nurses call in, young nurses who got symptoms after their COVID vaccine, call in sick the other day. And I said to the other nurses, they said, well, for Pete's sake, you guys need to be planning to get your vaccine when you're going to have a day off. They looked at me like I was crazy. They said, do you think we get any days off? They are not. We are afraid, F-R-A-Y, at this point, but we're holding up. I have a hard time talking about it, but the folks I get to work with are remarkable.
Thank you for that. Can you tell us a little bit about what kind of coordination there's been going on among the local hospitals? You have Earmac, Mountain View, IF Community Hospital. You've got Portneuf and Blackfoot and Rexburg. How is that all working?
Fortunately, we've maintained capacity in the state, and I get a report every couple of days on how hospitals are doing. Individual hospitals have at times been overwhelmed and had to go on diversion. As the regional referral center, we try very hard not to do that. We have been tripling up patients. We have overflow areas open. We're using all staff in what we call team staffing, in which you take an ICU nurse and pair them with a nurse who's not used to taking care of critically ill patients, in order to extend our nursing staff to do anything we can to stay open. We realize that other hospitals don't have that luxury of expansion that we have. So for instance, we are often in the situation of taking referrals from other hospitals in the region, including to the center of the state. We are fortunate that the entire state of Idaho has seen a lessening of cases. And so, for instance, my colleagues over at St. Luke's and St. Al's are seeing a decrease in cases. And while we're all in a category now called some strains, we are not under as severe restraints as we were, say, 3 weeks ago. So we're holding up. We're helping each other as institutions in terms of taking patients that can't be accommodated at their initial hospital.
Thank you for that. Moving over to vaccines, some people were wondering where they can get, are the immunization locations going to get posted? Are these our regular doctor's offices, pharmacies? Do you know anything about that?
It's unclear at this point, but we should get some real clarity next Monday with the posting on the Department of Health and Welfare coronavirus .idaho.gov, that there will be a place that you can look at what providers are available in your area and match one of those providers to when you're going to be eligible for the vaccine. So as of next week, I think that'll get clarified and be very helpful. We know that they're opening up centers, for instance, in fire halls, in gymnasiums. I think this is going to be mostly outside of physician offices, but we need to see those statistics and see. But it will be clear very soon.
And then related to that, and probably your answer will be the same, is who's going to let people know when it's their turn? I mean, you can go on and see the groups, but how do you know if we're running ahead of schedule, behind schedule, whatever?
I think what you're going to see, as I mentioned, is an overlapping in groups. So then I would anticipate beginning, as I said, February 1st, individuals ages 65 and over can start signing up for the vaccine. Now, that may not mean you're going to get it February 2nd if you go on the website February 1st. And I would go in earlier. I would go in and get lined up and get a date and a provider. But we're hopeful that this is going to move along much faster now with federal financial assistance to providers to be able to give the vaccine, and with opening up so that we're not holding back vaccine, and that we recognize that you need to be doing more than one group at once.
A friend told me that Eastern Idaho Public Health was taking names for people who wanted to be vaccinated. So I called and asked them. And they said, yes, they are. Obviously, I gave them my name and Jerry, but they took our phone number and asked if we prefer a text or a phone call. So obviously, it seems they're looking at doing some kind of a notification system, but I only if you call them. So I guess I would recommend people give them a call as well. Do you know anything about that one?
I've advised friends to do the same, and I know that the public health department is keeping a list. It may turn out, I wouldn't leave it at that though. I would advise people the first of next week to also get on the website because that'll be a larger coordination, and we will have more information on total number of providers by then.
Got it. Well, the last is more of a comment than a question. One of our members who's involved in emergency response, she has posted her concern of causing additional delays in response time during an emergency needs to be kept at the forefront when proposing changes in emergency declarations. My personal opinion. Any thoughts you want to share on that?
Yeah, I kind of gave you my 2 cents on that. I've tried not to be political, but I think this is a public health issue that upsetting our existing public health structure that is divided between authority, between the governor and the local government, cities, as well as the public health boards would be a grave mistake. That we have a system hadn't been utilized in this manner in a long time, but we have a system that can work, and I think disrupting that structure would be a grave mistake.
Great. There is one more question that just popped up. Somebody is asking, saying that Idaho has been getting about 20,000 doses per week. How will that increase with the new release schedule? Do you know anything about that?
Director Jepson was rather vague about that yesterday. We know that we should see an increase each week in the number of doses as Moderna and Pfizer have geared up production and as they're not withheld at the federal level. Right now, as I said, we've used 33,000 doses. We have 155,000 sitting in the state and sitting at local health boards and institutions. So we still have over 120 existing doses that need to be administered to people. And that's where I was pleased to see the governor opening up, starting to vaccinate EMS personnel and school teachers and school personnel on an immediate basis. And that we should then be able the 1st of February to start vaccinating anyone over the age of 65. So we don't have a number from the feds yet on even what next week's allocation is going to be, but we do expect it's going to have a substantial increase now that we're not withholding cases at the doses at the federal level.
Thank you. Again, Dr. Krell, thank you for a very informative program on something that's on all of our minds right now. We really appreciate your being. Thank you again. And I'm going to now turn the program back over to Rotary President Michelle Holt.
Thank you for the opportunity.
Thank you all for joining us. Carrie and Jerry and Dr. Krell, of course, thank you for a wonderful program. We hope you will join us back next Wednesday for our next Idaho Falls Lunch-In. Thank you all very much for joining us.